You're listening to Innovators, the podcast from Harris Search Associates, where we speak with global leaders in education, research, engineering, and the health sciences, and ask them to share lessons learned as they continue to advance the frontiers of innovation and discovery. Today's podcast will be led by Rick Skinner, Senior Consultant.
Douglas Miller is the founder and chief executive officer of the Canadian-based firm Cognitive Diagnostics. CD offers its customers real-world artificial intelligence solutions in the application of advanced computing to healthcare and healthcare training. This week, he was named Senior Associate Dean for Undergraduate Medical Education at the Medical College of Georgia, where he previously served as Dean. His role as CEO of Cognitive Diagnostics kind of culminates a career in which Dr. Miller serves as Dean of Medicine at 4 universities, specializing in cardiology. He held appointments on the faculties at the University of Alberta, the Medical College of Georgia, once before, the University of Texas Health Sciences Center in San Antonio, St. Louis University, New York Medical College, and the Veterans Administration. Dr. Miller, with all of that, it's a real pleasure to have you, to welcome to Innovators.
Thanks very much, Rick.
You and a colleague, Eric Brown, wrote in a 2017 article of the American Journal of Medicine that artificial intelligence, AI, was not specifically developed as a tool for healthcare. Now, that statement prompts me to begin our conversation by asking you to help us to understand how artificial intelligence, deep learning as it's called, and precision medicine became something more than concepts and ideas and are already being used and appear on the verge of becoming practical realities in healthcare.
Well, that's a great question and certainly a fair question, because every technology that's been developed will not necessarily be helpful in healthcare or in medicine. But certainly because medicine and healthcare are so complex and so data-driven, increasingly so, any technology that can handle and process large amounts of data, so-called big data, could be very helpful to humans. The capacity of machines to process large data sets rapidly was significantly enhanced in the last decade when graphic processing units that were originally developed for video gaming were brought to bear on artificial intelligence, which has existed as a discipline for half a century. But the computing power of these GPUs made it possible for algorithms and neural networks to rapidly iterate large data sets and to solve problems that humans couldn't solve, at least not expeditiously. So the capacity to take images, for example, medical images, and apply algorithms and rapid computing power to those images makes it possible now for AI or machine learning or deep learning algorithms to actually provide radiologists with assistance in disease detection. This evolution is quite remarkable because 15 years ago, while artificial intelligence existed as a discipline in computer science, the tools with which to really apply it in any application, including medicine, really did not exist. So around 2006, colleagues working in Canada, Jeffrey Hinton and others, developed the discipline within AI of deep learning. And deep learning really extends the capacity of AI from being supervised by humans to doing unsupervised machine learning and algorithm processing. A machine can actually be given a data set, such as a number of medical images, X-rays, if you will, can be trained on those images to recognize what a pneumonia looks like from a cancer. With a limited degree of human interface, can actually produce a diagnosis and a report. And all of that is possible by virtue of the work of several investigators, such as the one I mentioned, who were able to actually convert the computing power and the algorithms at the same time into real tools. So today we are able to benefit from that, not only in radiology, but in a large other swath of medical technologies and applications.
You've given us a sense of some of the applications of the technology. How readily have these applications been received by the medical profession. And following up on that, what outcomes or their use suggest that they will have continued value and utility?
So it's early days in the actual use of artificial intelligence or deep learning in medicine. There's a great deal of discussion about the potentiality of this technology. It is a high technology, unlike other things we use in medicine. So the challenge of technology insertion, especially with high technologies, is a significant challenge. Right now, artificial intelligence is being used in genomics.
Yep.
It's being used to help predict gene mutations and polygenomic abnormalities in certain disease sets, and that already is well underway. So the laboratory application of AI is well established, and very soon those applications will allow us to predict hospital bacterial resistance to antibiotics even before it becomes clinically apparent. But in the clinic, in the wards, in the ICUs, the applications of the technology are being tested. And part of what we believe at Cognitive Diagnostics is that our workforce must be ready to receive the technology and use it by being educated as to what it can really do. The complexity of managing chronic diseases suggests to us that this will be a very important application of AI in clinical medicine. If you imagine a patient with diabetes and other chronic conditions, looking back at the patient's record and using a form of AI called natural language processing, one can actually develop a predictive model that will show you the trajectory of the patient over the course of the coming years and allow you to anticipate complications and outcomes that could be prevented if in fact the model and its accuracy can be validated.
You know, even as I listen to you talk about these extraordinary applications which have such real potential, I have to talk about the economics of this technology, because it's very difficult nowadays to talk about healthcare and medicine without talking about cost. So let me use an example and to illustrate the question I'm interested in. In education, the joke is always made that overhead projectors were in bowling alleys before they were in classrooms. The point being that change comes hard in some professions. But in this case, instead of the technology actually reducing cost in some way, in most cases, the technology was sort of added or bolted on, and it was an additional cost for education. There were no significant cost savings, at least at that point. I guess I'm curious to know how doctors, hospitals, health centers, how have they dealt with the cost of what I suspect is not inexpensive technology?
Well, certainly any technology, when developed and commercialized, bears a cost, and this will be no different than our prior technologies that have been developed and utilized in medicine. I do believe that the lessons learned from lower technologies like the EMR and how it was inserted will be instructive to high technology companies that are investing a great deal in developing AI capabilities for their businesses, including healthcare. If one sets aside the recovery of their R&D costs and other acquisition costs for developing the technology as a actual commercial tool and just looks at the point of utilization in health systems and the cost of that, I would say that one of the main drivers of current healthcare cost and cost escalation is people, the providers, the staff, and the others that make the complex system of care that we operate possible. And anything that can be done to truly enhance the effectiveness of those people that are working in healthcare and make their jobs easier, reduce their pain points, and benefit them in terms of their ability to get things done effectively would be a value-added and cost-reducing strategy. So if you imagine a technology unlike the EMR that is actually efficient, advanced, and creates a benefit by reducing the amount of work, not adding to the work that providers and personnel do in healthcare, that kind of technology would be very valuable and highly cost effective. The insertion of AI through the proper acquisition and testing channels into healthcare, if managed properly, should offer those advantages.
I see.
That's not yet happened.
Mm-hmm.
And so therefore, the legitimate concern you express about it being an add-on, a bolt-on, a extra cost with nothing going away would be legitimate. But my vision of this is that AI will turn EMRs, for example, which are clunky and non-interoperable, into tools that can actually be used to benefit patients and providers and reduce the amount of time that's spent with documentation.
That leads me to another side of the whole question of new technologies in this particular profession. Patient and doctor relationships are probably among the most personal and direct ones we have in our lives. And those relationships are based on a degree of trust that develops over, in most cases, a long period of time. The physician's diagnosis and treatment are results of the doctor's training, but also her or his experience in dealing with cases of a similar type as the patient's. So how do the analytics and quantitative findings of data analysis, sometimes based on thousands, even millions of cases, how does that change the patient-physician relationship, if at all?
Well, that's extremely important. And as somebody who has spent a good part of my career educating young physicians and healthcare providers to practice humanistic medicine, we have to bear this in mind because there always is the chance that technologies will disintermediate the patient-physician relationship.
Mm-hmm.
We conclude our article, Dr. Brown and I, by saying that AI is neither astute nor intuitive, so humans will remain essential to the intelligent use of technologies like AI in medicine. We firmly believe that because patients will not be, in our view, ever managed independently by machines. There will always be the need for human involvement and machine assistance.
Mm-hmm.
And we believe that the two working together is a 1 + 1 = 3 solution, not just at a care delivery level, but also, once again, by reducing the burden of documentation and other things on physicians, it will liberate their time to actually spend more time with patients. And we believe that that time is extremely valuable. And if a machine can make that time more available to the providers at any level of care, that's a huge advantage. If you talk to many physicians and other healthcare providers, one of the main sources of their burnout, which now exceeds 50% in some professions, is the fact that they are being disintermediated from their originally intended professional interactions with patients. So a good machine will be subtly able to assist the provider in the care and thereby release the provider to do more in the way of humanistic pursuits and connect to the patient better, we think.
In a way that implies that we could actually enhance doctor-patient relationships.
That should be the goal. Yeah, I would totally agree that the goal of any technology should be to have a humanistic outcome, and the technology should be very much behind the scenes, very much in support of the humanistic goals, especially in a discipline such as medicine and healthcare.
I wanted to circle back to ask you where you see the technologies of AI, precision medicine, deep learning. Where do you see them evolving over the next decade? Will they empower patients to ask for more analysis before settling on a diagnosis and the protocol of treatment? For example, will the marriage of genomics and data and analytics confront patients with some very difficult choices, the need for which stem from the capacity of the new tools to identify at least potentially deadly outcomes in some cases due to inherited traits, and to do so earlier in the patient's lives, but still with some measure of uncertainty about the diagnosis? Does that in some way shift the relationships in some way between the doctor and the patient?
I think the first wave of AI that we are experiencing and perhaps passing through is the wave where AI applications are already assisting, as I mentioned, with medical image interpretation, to a degree introducing the capacity to do virtual medicine through patient app interactions and Q&A. Those early applications of AI are relatively simple in the context of what AI could do. Non-image based AI is the hardest AI.
Mm-hmm.
And therefore, we're entering now into the second wave, and eventually we'll move into what we will call the third wave of AI.
Mm-hmm.
And I think that in all industries, in all sectors, as we move into that third wave, we move beyond autonomous vehicles and facial recognition and machines winning games like Jeopardy and Go into the next set of AI, which is basically contextual adaptation, the ability to have a machine explain a phenomenon that humans actually would recognize relatively easily, but achieve that explanation with the same degree of trust and certainty that humans processing the same information would come to. So
Yes.
that's a bit of an arcane concept, but in the third wave of AI, for example, machines that are generative, they have the ability to generate predictions about things that we take for granted, like how many strokes of the pen it will take for you to write the number 4. Will it take 1, 2, or 3 strokes? A really sophisticated AI can do that, and that will be just a small example of how AI in the future can help us to understand every aspect of what we're doing in the patient care setting. So how many steps should it take to take out a gallbladder with a robot? How many days should a patient be in hospital given projected responses to antibiotics for pneumonia? How to use the information to create a logistical plan for care delivery in underserved areas using various clinical support decision tools. So the future of AI will give us what I call a companion in healthcare, companion analytics, companion diagnostics, companion therapeutics. The machine will become the companion of the provider and will reflect their knowledge and the knowledge of the discipline in a manner that can be confidently applied with a minimum of human interface.
That's remarkable. That's very, very remarkable to think about. But it leads me to one last question. You're an exception in many ways. You're an exceptional person in many ways. Been sought out for deanships in 2 countries, various institutions. You now are president of a company that is likely to be doing some of the very powerful and amazing applications of technology that we've described here today. But I suspect Dr. Miller is maybe one of a kind. So it leads me to ask, where are the cardiologists, where are the oncologists who have this aptitude for seeing how technology can be applied in medicine? Where is that going to come from if this technology is indeed to realize its full potential?
Well, it's a very, very good question, of course, and an important responsibility, because in order for the very bright computer scientists that are developing these capabilities and applications to actually optimize these systems for any application, they need to interface with people who are knowledge leaders, thought leaders in other fields.
Mm-hmm.
So when I would visit Dr. Brown at IBM's research facility in Yorktown Heights, New York, he would show me the 3,000 computer scientists that work there. We'd walk the halls and we'd talk about things. And he said to me, he said, you know, we've got the best computer scientists in the world working here with Watson and IBM, but what we need to know are what are the questions that you need answered. And I've come to understand that it's our responsibility as healthcare leaders and medical educators to bring those 2 worlds together purposefully and to create a dynamic that would allow for us to really advance both fields simultaneously. The scientists are incredibly bright, incredibly gifted, and have great insights into the capabilities of the tools, but they don't know what the problems and the questions are that need to be answered. And their first question is, what would you fix if you could? What we know, of course, is that there are many problems and many fixes needed in healthcare, and not all the answers are apparent. So the goal of our company and the goal of this, I think, next generation, the third wave of AI, is to enter into a mode which I call precision education for precision health. If you can give people a better understanding and skill them up both in the workplace and in schools and professional programs and get them enough knowledge to know how the technology works to the degree they need it, they will then say, you know what, this technology could solve this problem that I'm aware of and that I deal with every day. And I think that that connection is the power of any innovative new direction that we've pursued as humans. And I think that it's our responsibility to see those connections happen. And by doing so, I think that the future is limitlessly exciting and the potential is incredible.
Precision education for precision health. I think that's something I'd like to take away from today's talk, because in some ways it encapsulates what we're trying to understand, and that is, where is the talent going to come from? And I think you're absolutely right. It's going to have to be very purposefully engineered, if you will. Dr. Miller, I cannot thank you enough. First, let me not leave without, again, congratulating you on your newest appointment. As a native Georgian, I'm glad to see you back in the Peach State. We want to thank you very much and for taking time out to be with us on Innovators, and we hope you'll come back.
Absolutely. Thanks, Rick. I enjoyed it greatly. Appreciate it.
Thank you for listening to Innovators, a production of Harris Search Associates. We'll have more insightful conversations with global thought leaders to follow.